Welcome, everyone, to another episode of Medical Millennial, the series for ECPs that are crazy about ocular disease. I'm joined by a very, very special guest, Ben LaHood. Ben, would you like to introduce yourselves to our audience and tell them where you practice and what you do?
Yeah, thanks, Emily. And it's really lovely to meet you. I've been a big fan. I follow you on social media and I love what you do. So thank you so much for having me. Yeah, I'm an ophthalmologist and I specialize in refractive cataract and laser vision correction surgery. I'm originally from New Zealand, as you can probably tell from my accent, and I now live and work in Adelaide in Australia. So it's a beautiful place. And if anyone ever comes over this side of the world, please look me up and come visit. It's beautiful. Uh, I work in private practice and I also work in the public teaching hospital. So I like having students and trainees that I can ask questions of and share knowledge, and that's great. So I did most of my training over this side of the world, but I did come and do some observerships over in the US. So I spent some time in Houston and in Sioux Falls, seeing some of my American heroes of refractive surgery. So I know a little bit about the American system as well. But yeah, mainly cataract and a lot of sort of the laser side of things is quite interesting. We'll talk a bit more about that it's expanded from just low myopes coming in and wanting to get rid of their glasses to looking after keratoconus and more unusual things as well. And I think we'll get into those topics too.
Yes, that's exactly what I wanted to talk about. And interestingly enough, because I've been doing a lot of 1099 contracting, working in different offices, I maybe don't have as much of like a set position when it comes to cataract or refractive surgery. And what I mean by that is I don't always follow up with a lot of my patients. But I feel like there's a lot of optometrists that sometimes are in the same situation. And maybe we just kind of need to use the right language. And we want to make sure that we're still guiding patients in the right direction when we do recommend them for cataract surgery. Dr. LaHood, as I was kind of thinking about these questions and putting this together, one of the things that I wanted to ask was, do you agree with the term premium IOL? Because the way I started thinking more and more about this, I was like, why are we calling it a premium IOL when really I can just maybe rephrase what I'm saying and offer this as a patient, not as something that's elective or, costly, but something that's a privilege to now be able to correct their refractive error in cataract surgery. Does that make any sense? Is premium IOL maybe a term that we shouldn't be using?
Straight off the bat, Emily, with the best question ever. This is like my pet peeve because I hate the term premium IOLs because, and let me explain myself, because I think there'll be a lot of, especially American surgeons who would say, well, look, there's a lot more on the line here. We're sometimes doing refractive lens exchanges. So, there's a lot more effort, there's a lot more thought, but I think we're doing the same surgery. And I think the key thing is, imagine for the optometrist listening, imagine if the only glasses you could give as standard were spherical. And anytime that you prescribed a cylinder, people would say, oh, the premium lenses. Oh, you're getting the premium glasses. Wow, that's going to cost you a lot more. And I hate that because leaving someone with astigmatic refractive error is no better to me than leaving them out of focus with sphere. If anything, it's worse. So the idea of a premium lens being including a toric lens, I think is disgraceful. I think that certainly presbyopia correcting lenses could be considered an upgrade. And I think that's completely reasonable because there is a lot more. I don't believe there's more effort because I don't put any more effort into getting a perfect outcome. Not that I'm perfect, but I don't put any more effort into getting a perfect outcome with a monofocal spherical lens than I do with a trifocal toric lens. I still want that patient to be absolutely happy. I want the best outcome for them. But I do know that this is a patient that may need a little bit more support, a little bit more care, a bit more chair time. But ultimately, I don't think that a toric lens should be considered premium. And I do walk the talk because I was actually offered a job in New Zealand where the practice said, look, you can work here. We'd love you to come and work here, but you're not allowed to use premium lenses because our optometrists will not refer to us, because if you're getting rid of the need for glasses completely, why would they refer their patients here? And I got on my high horse, I I'm not the world's most moral person, but I was like, well, if my mum came in here and was not offered a premium lens solution for fear of annoying the referring optometrist, I think that's terrible. So, it is more complex than I'm making out and saying that no, everyone should have access to every lens. One side of it, I'd be interested in your thoughts would be, what do you think about referring to someone that does put in premium lenses? Do you worry about losing your patients?
Absolutely not, because I think at that point we're managing a lot more in that patient. There's always a younger patient that we may refer for cataract surgery, but most often those patients are, routine patients. And I think the same argument was used once upon a time with optometrists and LASIK. Well, LASIK
Yeah.
reduced our profession. And as our profession, like in this podcast, is becoming more medical, I never even think about that. But that's a really interesting point that you bring up. So maybe optometrists in your area of the world can maybe take maybe a lesson from optometrists here and kind of say, hey, don't sweat that. Yes, there's glasses and contacts and refractive correction, but also there's so much that we can do when it comes to managing disease.
Yeah, well, it goes both ways because I'll still get referred, irregular corneas, this sort of thing, and I'll think, wow, you would do so much better with a semi-scleral lens. You need to go back and get a hybrid contact lens, and I don't worry about losing that patient because I think, well, many fish in the sea, and I also think what's best for that patient, and also from my reputation, I don't want to operate on that eye and have a poor outcome. That's probably worse than sending them back to the optometrist to say, can you help me? And I'm a really big proponent of co-management, of working together. Like you said, we have so much in common. We're working with the same tiny organ. The only difference is that I cut it. That's really the only difference. And I know people over this side of the world get really up in arms when I make those sort of comments because they think, oh, it's a slippery slope. Before you know it, optometrists will be operating and you've ruined it for everyone. But not at all. I love working with an optometrist, and I work closely with an optometrist in my practice. And we both see the same patients. So we see them usually in succession, and we both offer them different things. Sometimes I'll see a patient and I'll say, I think we should do LASIK. And my optometrist might say, whoa, 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 hold on a second. This person has some quite bad dry eye signs. Just back up there, cowboy. Let's just think, what's the best thing for this patient? And I love that.
Yeah, I think you hit the nail on the head. It's really what's in the best interest of patients. And I think we all should be thinking about that when it comes to doing those referrals. And there's things I'll do in my exam too, where maybe it's a patient I'm fitting. I love doing multifocal contact lens fits. It's one of actually my favorites that I don't talk about very often, but I love the optics and the complexity between multifocal contact lens fits. And I feel like that's a direct translation to them being a good candidate for a multifocal IOL whenever the time comes. So that excites me to open that world and kind of be a little bit more of that bridge in their future surgical options.
Yeah,
I wanted to ask you though, is there something new with toric lenses, toric IOLs that you've been looking at? Because I know you do a little bit of research too. Is that correct?
I do. I'm one of the weird refractive surgeons who, refractive surgeons don't have the best reputation amongst our colleagues. I think ophthalmologists think of us as being sort of cowboys, and I think optometrists sometimes think of us as just being laser jockeys. So I know you don't, but that's fine. But I am the weird one that likes research and likes teaching and enjoy that sort of thing. So I do a lot of research on astigmatism management and toric lens calculations. So in terms of what's new, I'm going to be a little bit biased and say what's new is something I've produced, which is an app or website called Toric Pro. And it's freely available online. And the idea behind that is what I wanted to create was a platform where, any eye care professional could look at an eye and take a subjective refraction, because we all know that that's what's really telling us what this patient wants, not the optics of the eye, but what the brain wants, the subjective refraction. And from that, they would be able to judge whether this patient that has a toric IOL could they have a better rotation of that lens? Could they have a better positioning that could give them a better outcome of their vision? And, we don't necessarily have to do it. We don't have to follow through with that surgery and rotate the lens, but it's really nice for anyone to be able to, you could see a patient in your clinic, you could get their clinic letter from their surgery, have a look at the eye, see where the toric is lined up. Maybe they have some residual astigmatism, and you would be able to write back to the surgeon and say, look, when I saw Mr. Jones, his refractive astigmatism was he still had 2 diopters of CIL, and I noticed that his toric was at this axis. I looked at Toric Pro and it said that maybe we could rotate the lens. Now, I don't know if your referring ophthalmologist would be like, Emilie, how dare you? I can't believe you'd tell me what to do. But I personally love when I get a letter from an optometrist, and this slightly changes track, but I'm a huge proponent of optometrists telling me more information about the patient, because you usually know them really well. You've often seen them for years, have longer appointments. And if you could tell me, hey, Ben, this would be a great candidate for a toric lens, I love that. I love that. So I appreciate that kind of correspondence. And I think any new generation ophthalmologist will appreciate that. So a little bit off topic, but that's what excites me about, toric IOLs at the moment is that ability. I think so. The IOL producing companies are making incremental gains. And I think the 2 gains that I'm seeing at the moment are the Clarion material from Alcon that unfolds faster inside the eye. And so it means that at the end of, a fast cataract operation, the lens has already positioned itself, because what we know is any kind of rotation of the toric happens early. And so the stickier and the more completely unfolded it is at the end of the operation, the better. The other one is that from Johnson & Johnson, their toric lens has some sort of rough haptics that grip the capsule a little bit better. So those sort of things are exciting. But the biggest one that's going to be a game changer for the US is having low-powered torics. And so everyone always asks me, Ben, what's your threshold for a toric? Like, who should get a toric? And I'm in a really privileged position, because everyone should get a toric, just about. Unless they have a lovely soccer ball of an eye that doesn't get a toric, most people would benefit from a low-powered toric. But sadly, they haven't been FDA approved in the US yet. And so surgeons are doing an amazing job in the US, and they're using corneal incisions and these sort of things, but nothing is quite as precise as putting a lens in the eye that suits the eye.
And Ben, is the thought behind that to just relax that area when you're saying that they do those incisions? It's to relax the astigmatism in a sense?
It is. It's exactly right. So the idea is, and this is what I was taught when I was training, I sound like an old man, is that when you make a cut on the cornea, you can expect a flattening effect at that incision. Now, what we know, and I'm sure you've thought about this a lot with contact lens fitting, we don't understand corneal biomechanics as well as we imagine we do. Mm-hmm. And so, you might get a contact lens that you think fits perfectly, and then you come back for follow-up and it's warped and you think, what's going on here? And so the same thing happens with incisions, where we think, right, I'll make an incision at 90 degrees that will take care of their withdrawal astigmatism, fantastic. And they come back and they've got more astigmatism. And so we don't really understand the corneal biomechanics. So I think that the idea of incisional astigmatic management is great. It's a great idea. It's just not particularly, it's a bit crude. It's not as refined as it could be, but that's surgeons making do with what they've got.
When it comes to surgical outcomes, what would you say is considered to be a poor surgical outcome?
Oh, I'm going to put my foot in it, because I'm sure if any of my patients are listening, they'll think, I've had a bad outcome. That's terrible. So the idea of a 20 happy patient is touted quite a lot. If the patient's happy, leave them alone. That's a good outcome. And I often say, you can't improve your outcomes unless you know your outcomes. And so I still refract even my happy patients. And some people might say, well, why would you show a happy patient that they could see better? But I do think that happy patients don't worry about that. They're fine. And so for me, a poor result would generally be someone where I have aimed for something and I haven't achieved it. That's I know that's a really nebulous concept. It's not really narrowing down what I mean by that. But say I've promised someone monovision and I don't achieve as short a sight as I want. They're sort of in the middle ground. They're not good for distance. They're not good for near. To me, that's a disappointing outcome. And the disappointing outcomes for presbyopia correction are generally when patients say, my reading vision is insufficient. I still need reading glasses. And I think that's probably the part that at the moment, we don't have really good methods of predicting who will do well with multifocal intraocular lenses, because we've got all these great technologies, but we're still seeing a bit of variation in how well people can see up close.
Mm-hmm. Do you think that because this is just a thought that I've had of recently with Vuity coming out, do you think any of these presbyopic correcting drops will have a space in refractive surgery? Perhaps I'm imagining maybe for a younger candidate than a younger LASIK candidate, perhaps more so than an older candidate that doesn't have any accommodation now that we've removed that lens. But where do you think that they may, if any, have a space in refractive surgeries?
And I'm on the fence because I think there will be patients where I can eke out a little bit of extra accommodation. Mm-hmm. And I think there will be those early emmetropic presbyopes who I don't really want to operate on because it's scary. Basically, if you don't nail them and get them perfect, they're often unhappy. They want the world because they've just lost their near vision. And as I get older, I can appreciate that. And so I think Vuity will have a place for them just to hold them off until they are ready for surgery. I don't see it as a magic elixir. And mainly that's because we do know that the pinhole effect works. It definitely gives extended depth of focus. It's wonderful. But we also know that pilocarpine with chronic use does have its own problems with retinal detachments, chronic inflammation, iris problems. So I don't see that it's a great long-term solution for everyone, but I think those early presbyopes, I think that's where it will really work. Have you been using it much?
We've been doing a little bit here and there, and another doctor that I'm working with, we're kind of sharing feedback and testimonial, and we're predicting, of course, it's working in the early presbyopes, low myope area. Yeah. Of course, those hyperopes, they're the ones that want it the most, right? Because now they're working past their distance and having to accommodate through not only their distance prescription, but then their presbyopia as well. So we think that those ones are predictively going to be the ones that have a little bit more headache too.
Yeah.
Not just from the drop, but also just because of their accommodative system. So it's interesting. It's some people we've been like, you're probably not going to be a good candidate. And then they're like, we like it.
Yeah.
And I think there's something to be said too for the type of person that you're doing it for. Whenever I do a multifocal contact lens fit, I have to really assess what are their expectations and how high are they? I think that that's always the delta in the situation that you might not necessarily be able to predict for, but probably for selecting better candidates for Vuity, then we're probably going to end up getting, like you said, that better expectation or that better result. But it's early to say. So I think we'll learn more as we do a little bit more.
Yeah, I think so. And I think it's one of those drops one of those treatments where I think, would it pass the test of would I use it myself? And you're far too young to be worrying about that. You could have the test, would I use this for my mom? And I think it is. It's something I would try because I don't see a real particular downside to it. And for some people, it just won't work, and that's fine. The other thing I just wanted to say was about the multifocal contact lens use, and something that might be interesting to your listeners is I see a lot of people that get referred to me in multifocal contact lenses for multifocal IOLs. And I always like to think of it as a test where if they like the multifocal contact lens, that definitely means they will like a multifocal intraocular lens. But the flip side isn't always true because some people, and you might have seen this, some people don't like a multifocal contact because there is that little bit of movement with each blink. And some people find that they have to find a sweet spot still, that sort of thing. So I don't let that completely put me off using a presbyopia correcting lens for those patients.
Are there any multifocal contact lenses that you feel correlate more with with success in multifocal IOLs? Have you noticed any
Yeah.
trends with it?
Unfortunately, I haven't. And I don't know of anyone that has. I think a lot of refractive surgeons still feel as though we don't have a good simulation. I know that there's a bit of work going on at the moment for virtual reality simulations of multifocality, which is quite cool. It's quite a cool idea. And the next thing that's coming also is our ability to ray trace an eye. So actually present a patient with, this is what we would expect the quality of your retinal image to look like if we used this multifocal, if we used this toric. And that's really nice, because one of the things that's difficult, and I think especially in the US, is telling a patient, this is how much improvement we expect you to have if you pay this extra money. And to be able to actually show them, this would be what the letter E would look like on your retina. This would be what it would look like, and show that, yeah, you will lose a little bit of contrast, but you gain all of this. And I think that's exciting to me, is being able to simulate that, because simulating multifocality to someone and trying to explain the optics of diffracting light and all of these things, especially often you're explaining it to someone that's 80 years old and probably only understands a telescope. I think that's really difficult concept. So anything that you can show them. But also the other thing about simulation is it's really hard to simulate with a contact lens when they have a cataract. So we're a bit out of luck there.
Yeah, that's actually a really good point that you bring up. And I know you guys have so many things that you need to talk about when you're going to do your consultation for surgery. So that's why I always try and at least get that conversation started when I'm in my exam room ready to refer them. I cover like the baselines, and then I kind of say, all right, they're going to talk to you about this in more depth, but I just want you to start thinking about how you want to see after surgery. That's a line that I use because, I think in their mind, they're going for this medical procedure where, okay, it's going to all be solved, but asking them, how do you want to use glasses, if at all, after surgery, posing that in their mind is sometimes I get like a blank stare back, and they're like, I don't know. No one's ever asked me that. How do I want to use glasses, or how do I want to see? So maybe a tip for other optometrists is really get into the lifestyle of the patient and communicate that with your surgeon. I'm big on prescribing for lifestyle. So really dive into how they're using their vision, how they want to use their vision, what tasks you do throughout the day. And even in prescribing, I think you're going to have a lot more success because you're meeting them in their actual lifestyle.
Oh, absolutely. You'll get a happier patient. They'll feel like you understand them. I love when they come from you and they've already had, that little bit of a chat just to broach the topic. And the flip side of that is when I muck up and I say, I'm going through all this stuff about multifocality and torics. And then at the end they say, but I just want to wear my glasses. I'm like, well, why didn't you tell me? That's easy. That's fine. And so it's really efficient. And I can't think of a single surgeon who wouldn't enjoy an optometrist to start that talk.
Great. And then I just want to touch on the last subject, the last question that we have, but you were, branching on new laser regulations for keratoconic corneas. Can you tell us a little bit more about that? Is that just something in Australia? Is that in the US as well?
Yeah. This really excites me, and it's something I do a lot of. And so much has changed with keratoconics. I mean, when I sat my specialist exams, if you were presented with an OSCE case, an exam case of keratoconic, if you even mention the word laser, you're fired. Like, you're out. That's the wrong answer. And now, when I see a keratoconic, I'm already thinking, wow, how could I reshape this cornea? How could I improve this person's vision? And the big things that have changed are, firstly, cross-linking. Like, that's just a massive game changer. And the second one is the laser technology that's changed, that we can now do truly topographically guided treatments. And so it is worldwide. And in fact, some of the best developments that have come of the topographically guided treatments have come from the US. There's the Forsytes system that's been employed by Alcon from Mark Lobanoff. That's amazing. And so my sort of algorithm, if it's interesting to listeners, you're welcome to cut this out if it's too technical. But what I think is, say I have a keratoconic that comes and sees me. Step number one is always stability. Are you stable? And so if I've got information from their optometrist, maybe if they have refractive data or hopefully topography, but not many optometrists here have topographers. If I've got a long history of stability, then I think, right, how old is this patient? And generally, if they're under 30, I think, right, you're still in the danger zone. You could be changing. So let's just watch you at first. If they're over 30, I think, right, well, you probably have been naturally cooked and you're probably quite a stiff cornea now. So I have a much lower threshold for saying, let's not cross-link you. Mm-hmm. From there, if there's any hint of instability, or if they're younger and they want to consider laser, I cross-link them. And the threshold for cross-linking has got so much lower because, even if I have a healthy-ish eye, but just a little hint of form frust keratoconus, mm-hmm. I want that cross-linked. The days of waiting for glaucoma damage to treat glaucoma have gone. We don't want to be the ambulance at the bottom of the cliff. You want to preempt it and treat it. So, I treat the good eye earlier than the bad eye now. And then we do know from huge studies that with cross-linking, we can expect a little bit of shape change, usually for the better. And so I'm not a big fan of combining a treatment with cross-linking because I think I want to see the outcome of this cross-linking before I reshape this cornea. And so the thing that's changed with the laser treatment has been we've gone from doing these sort of big ablations to try and treat someone's refractive error to now what I do is I will generally treat the central 1 millimeter of a cornea, make it more of a regular shape with a really wide transition zone so that I'm really minimizing how much tissue I'm taking away. And, obviously every eye is different, but we're seeing results where it's quite standard to see someone's post this laser treatment unaided visual acuity being as good as their previous best corrected visual acuity. Wow. And I'm telling people, look, I'm not expecting you to be glasses free after this. We're trying to give you the best possible quality, best corrected vision. Now, some of them are lucky and they're great. They're fantastic. Some of them still need another either lens surgery, laser ablation, or glasses or contact lenses. But we're able to get rid of some of that irregularity and give them quality vision, and that's crazily different to, all right, you wear an RGP lens and then when your cornea fails, we will do a corneal transplant. Right. And it really hasn't been that long.
Yeah, that's amazing. And I imagine for so many patients that have keratoconus, they've just been told no, 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 over and over and over again. So that is really exciting. Thank you for sharing that because I think it'll give us a lot of hope and a lot of options to say, hey, there are more options that exist now and let's change this for you. I think every optometrist and surgeon would feel like a hero in that patient's eyes. So that's exciting information that we can share with them.
Absolutely. And I think that, say optometrists out there are thinking, if when I think about it, I've got a few keratoconics I've just written off. I mean, in a nice way, I've just said that's as good as you get. Send them back because, if I get sent someone with horrendous keratoconus and I say, look, no, you're already wearing the best option possible. Keep your lens. That's fine. No harm done.
Mm-hmm. Yeah. Even for patients that don't maybe fit the typical profile for LASIK, they may be asking about LASIK, right? Because that's the term that everyone knows when it comes to refractive surgery. But even if it pushes them out of the candidacy for LASIK, I still will send them. I tell every patient there's no harm in getting a consultation, just knowing where you stand. And I think that there's an important part in that. I take my evaluation very seriously. I try to be most medically based. But at the end of the day, I'm perfectly fine saying, I'm not the surgeon. I'm not doing these procedures. They know a lot more about what you look like and how you're going to do, and they can predict that outcome much better, and they have better measurements that they'll end up doing. So let's see what they say. And through a really collaborative approach, like we were talking about earlier, it's just in the best patient's interest to have both people involved in that decision.
Yeah, absolutely. It's the same for me. If I have someone with, glaucoma that I'm worried about, I'll say to them, you're going to see a glaucoma specialist. They probably offer you some surgeries that I don't do. So I don't know what's going to happen next, but I'm going to get you to see the right person.
That's right. Well, Dr. LaHood, it's been such a pleasure. Thank you so much for joining us on Medical Millennial. If people want to get in contact with you, how can they do that? I know you have a wonderful podcast as well. So can you share some of your information?
Yeah, absolutely. And thank you so much for having me, Emily. I love all the content and the education you do, and also how open you are with sharing your experiences. It's amazing. More people need to get in and watch your Instagram and everything you do. So to get in touch with me, I'm happy to share my email address. It's Dr. Ben LaHood. Ben at drbenlahood.com. Website is drbenlahood.com. And you're welcome to follow me on Instagram at Dr. Ben LaHood. It's all pretty simple. I also run two very different podcasts. One of the podcasts is called The Second Look. It's supported by Alcon, and it's where I've had a chance to have a sort of a light-hearted chat. So sort of like a behind-the-scenes chat with some of the most famous people in the eye care world. So that's been amazing, getting insights into people that you usually just see on the podium. And the other podcast that started it all for me was Ophthalmology Against the Rule. And that's been really popular with optometrists. I expected it to be ophthalmologists and ophthalmology trainees, but optometrists have really enjoyed our deep dives into topics that are relevant to all eye care professionals. So I run that with a glaucoma surgeon called Nick Andrew, who's in the Gold Coast, Australia. And we take deep dives into topics that are often overlooked because, like you, Emily, we're eye nerds and we love eyes. And some of the topics that have been interesting to optometrists have been OCT and glaucoma, myopia progression, those sort of things. So if anyone wants to listen to those, they're available online. Just Google them or have a look on the podcast app.
We'll be sure to link all the information below. Well, guys, thanks for joining us for another episode of Medical Millennial, the series for ECPs that are crazy about ocular disease. Until next time, bye.